This video is on secondary amenorrhea. After viewing this VAP, you would be able to understand the definition and pathophysiology of secondary amenorrhea, the causes, and their clinical features of the condition, as well as important features of history taking, physical examination, as well as the investigations and management involved. Menstruation is defined as the cyclic, orderly sloughing of the uterine lining in response to the interaction of hormones produced by the hypothalamus, pituitary, and ovaries. The menstrual cycle is divided into two phases: the follicular or proliferative phase and the luteal or secretory phase. In the absence of pregnancy, menstruation takes place after the end of the luteal phase. With a drop in the levels of progesterone, the endometrium sheds and menstruation results. Secondary amenorrhea occurs when a patient who has passed menarche has an absence in her menstrual periods for 6 months or longer. Primary amenorrhea, which is not discussed in this video, is defined as a failure to reach menarche by 16 years of age. The broad causes of secondary amenorrhea include disturbances of the hypothalamus-pituitary ovary axis leading to irregularities in the menstrual cycle and outflow tract obstructions. Other important causes of amenorrhea that must be excluded include pregnancy in all women of childbearing age, the use of contraceptives, and hyperthyroidism. Secondary amenorrhea can be caused by disturbances of the hypothalamus-pituitary ovary axis leading to irregularities in the menstrual cycle. The causes of secondary amenorrhea can be localized depending on the area of disturbances. Pathologies affecting the hypothalamus and/or anterior pituitary gland can cause hypogonadotropic hypogonadism with low serum levels of FSH and LH. Pathologies affecting the hypothalamus include various factors such as stress, severe weight loss, excessive exercise, psychiatric stress such as anorexia nervosa, or pharmacological agents such as steroidal preparations, psychoactive drugs, and narcotics. A pathology that can affect the anterior pituitary gland is hyperprolactinemia with high levels of serum prolactin. Hyperprolactinemia can be caused by a prolactin-secreting tumor in the pituitary gland and the high prolactin level, which would then cause a cessation of menses.
Other symptoms that a patient can present with include headaches, visual disturbances such as bitemporal hemianopia, and galactorrhea.
There are also drugs which could lead to hyperprolactinemia such as cimetidine, metoclopramide, or even antipsychotic drugs. Another cause includes a condition known as Sheehan's syndrome. This takes place when there is a severe postpartum hemorrhage during delivery, causing necrosis of the anterior pituitary due to severe hypotension, as the pituitary gland is one that is supplied by a watershed of blood vessels. Pathologies of the ovaries can also lead to secondary amenorrhea. The first broad group of pathologies is ovarian failure, leading to hypergonadotropic hypogonadism with a rise in FSH and LH. This could be due to a chromosomal defect such as Turner syndrome or Turner's mosaic. Chemotherapy or radiotherapy may also result in premature ovarian failure. The other common condition is polycystic ovarian syndrome, which results in eugonadotropic hypogonadism. The condition is defined by the Rotterdam criteria, with at least 2 of the triad of oligomenorrhea and anovulation, hyperandrogenism, and the presence of polycystic ovaries. Polycystic ovarian syndrome is associated with obesity and metabolic syndrome. The last groups of conditions include outflow tract abnormalities. One of them is Eschermann's syndrome, where there is scar tissue within the uterine cavity. This is usually due to a post-surgical trauma of the endometrial lining or infections, leading to adhesions. Another cause would be cervical stenosis, where there is a blockage that occurs in the cervical canal, leading to a physical obstruction. This can be caused by surgery of the cervix. Patients with secondary amenorrhea should be asked questions to localize and narrow down the possible causes of their condition. Details that could be elicited include and are not limited to their eating and exercise patterns, emotional stresses, chronic illnesses, visual disturbances, symptoms of hyperandrogenism, and symptoms of hyperthyroidism. Information concerning the patient's menstrual history, past medical history, and family history of menstrual abnormalities should also be elicited. Lastly, taking a sexual history is important when considering the possibility of pregnancy in a woman of childbearing age. For physical examination of the patient, features that should be looked out for include measuring the patient's height, weight, and calculation of their body mass index (BMI), a neck examination to check for a thyroid mass, looking out for clinical features of hyperandrogenism in PCOS, as well as a pelvic examination to look out for evidence of an outflow tract obstruction. For PCOS, this is the Ferriman-Galway scoring of hirsutism from grade 1 to 4 in mild cases to severe cases respectively, where hirsutism can occur on the chest, abdomen, as well as the back of a woman. The initial workup for secondary amenorrhea includes a urine pregnancy test and serum hormones such as FSH, LH, prolactin, estrogen, and a thyroid function test. Subsequent investigations depend on the likely cause of the secondary amenorrhea. This can range from blood tests such as serum testosterone in PCOS, radiological investigations such as pelvic ultrasound, and karyotype analyses in Turner's syndrome. The management of secondary amenorrhea is targeted to the cause of the condition and will not be discussed in detail in this video. Thus, this concludes the VAP on secondary amenorrhea, where we have discussed the clinical diagnosis of secondary amenorrhea, the causes, important history and physical examination findings, investigations, as well as simple management of this condition. Quiz time. Question 1. In the normal menstrual cycle, the shedding of the endometrium is caused by a decrease in serum levels of which hormone? Question 2. A 45-year-old female presents to the clinic with secondary amenorrhea and features suggestive of polycystic ovarian syndrome. What condition is polycystic ovarian syndrome an example of? Question 3. A 30-year-old female presents to the clinic with an absence of menstruation for 6 months. What investigation is included in the first-line investigations for her?